Here's the special test for the shoulder. The first one is the apprehension test. This is for anterior instability. You abduct the shoulder to 90 degrees, then externally rotate while you watch their expression. A look of apprehension is a positive test for anterior instability of the shoulder. The next one I'm going to show you is the Norwood test for posterior instability. So elbow flexed, shoulder flexed to 90 degrees, and then you stabilize the scapula and you put a posterior force through the long axis of the humerus. Apprehension or complaints of pain are positive for posterior glenohumeral joint instability. And then for inferior joint instability, it's called the sulcus sign. Elbow bent 90 degrees, you place an inferior force here, a downward force on the forearm to pull the humerus down, and a positive test is a sulcus being formed here off the acromion, between the acromion and the greater tuberosity. That is for inferior instability. Okay. The acromioclavicular shear test is a test for the acromioclavicular ligament. So you grab the acromion, this square part of the shoulder, take your other hand, grab the distal clavicle, and you apply an anterior force first. This checks the anterior motion of the clavicle, but this is a superior and inferior acromioclavicular ligament. And then I can use my fingertips and pull backwards. Instability and or pain are positive tests. Acromioclavicular shear test. The next one is the Jurgensen's test. This is the test for the bicep long head tendon integrity in the groove, and integrity of the transverse humeral ligament. So person's elbows flex 90 degrees, and I will say, don't let me pull. I'm attempting to pull down and out. So I'm resisting her elbow flexion and internal rotation. So she's pulling in and resisting my downward pull. A positive test is a popping sensation in the anterior shoulder that tells you that the transverse ligament is no longer holding the bicep tendon in the groove. The next one is the Speeds test. This is for tenosynovitis of the bicep long head tendon. So what you want to do is apply resistance and allow movement through the range. So go ahead and push your arm up as fast as you can. A positive test is anterior shoulder pain. Go ahead and push. This tests the ability of the tendon to glide in the sheath, unlike a manual muscle test where you just say, don't let me push here. So you can have a tenosynovitis and have it not show up when you don't do the speed sign, right? So you want to do the speed sign, again, push up. Pain is a positive test, and you want to create resistance through the range. One more time, resistance through the range, okay. Next one is the drop arm test for rotator cuff tear. Two ways to do this. Abduct the arm to 90 degrees and have the patient lower the arm slowly. They should be able to lower it all the way down. That would be a negative test. A positive test is they lower it, and as they get down towards this range, the arm just drops. That is the area of the range where supraspinatus is integral in doing abduction. If the tear is not serious, you may do the test like this, where you abduct the arm and then you say, don't let me push, and you bounce the arm down. If they have a torn rotator cuff, that arm will drop. Okay, that's the drop arm test. The supraspinatus test is also known as the empty can test. You abduct the arm to 90 degrees, move it in the plane of the scapula, internally rotate. This isolates the supraspinatus muscle. It's a manual muscle test. Don't let me push. Okay, pain and or weakness is a positive supraspinatus test and implicates tendinitis of the supraspinatus. And then the Hawkins-Kennedy impingement test. This is for impingement of the rotator cuff and or biceps long head tendon. So you just take the arm and you horizontally adduct so that the elbow's in line with the nose, and then you passively internally rotate. A positive test is pain in the anterior or superior shoulder. Stretching on the posterior aspect of the shoulder is not positive. And that leaves one more test, and it is the clunk test done in supine. So the patient lies here, lying on the pillow, right? Okay. You elevate the arm as high as you can. Try to clear a pinch. Did that pinch? And then you grasp with a cylindrical grip as close to the axillary region as you can. So proximal humerus, I'm applying a compression into the joint, and then I'm scouring in the inferior direction, superior direction, anterior direction, and posterior direction. Positive test is a palpable or audible clunk of the shoulder, which would indicate a glenoid labrum tear. That's it, special test of the shoulder. All right, these are the counter strain techniques listed in your manual. The first one is counter strain for pec minor. The tender point is found here at the concavity of the clavicle, just below it. That's the coracoid process. This muscle fans out to ribs 3 through 5. So the tender point is like right here, okay? Just a little bit below the coracoid process. The way to counter strain it is you move the patient's arm across their body, you push their scapula into protraction kind of towards the opposite hip. Monitor the tender point here with your other hand, and notice how my arm is kind of notched into the table here to support it. This is a lot harder if I don't have support under my elbow. Once you find the position where the tender point is gone, you hold this for 90 seconds. So this is the counter strain position for pec minor. The counter strain position for upper trapezius is also done in supine. So the trigger point here is found right here in the meaty portion of the upper trapezius muscle. Really easy trigger point to find. To shorten it, you want to side bend towards, rotate away, and then make sure they relax their head. So you can tell by the sternocleidomastoid if it's relaxed. Reassess the trigger point. If it's still tender, you can elevate the shoulder, but make sure that you're doing that passively and they're not holding it actively. So just kind of pull it up. This is the position you hold for 90 seconds, and my thumb here is just monitoring the trigger point to make sure that she's not tightening those muscles up. So this is the counter strain position for the upper trapezius muscle. Lie prone for me. So the levator scapula muscle runs from the medial, superior medial portion of the scapula up to the cervical spine. Just turn your head to the right. Yeah, there you go. If, actually you should turn your head to the, yes, there. Let me think for a second. I stretch it by looking, no, sorry, turn away. If you turn away, you shorten this muscle here, and what you want to do, the muscle runs in this direction, so you're going to take your hand, the heel of your hand on the lateral border of the scapula, and you're going to glide the scapula superior and medially. So I'm pushing superior medially, palpate the trigger points here. It's a really common trigger point. If you push hard enough, you'll get that trigger point to disappear. Monitor it with your fingers for 90 seconds, and then passively return to neutral. So the counter strain position is simply a medial superior glide of the scapula. Okay? And then, can you sit up for me? And maybe face, you should face the Okay, so now the last two counter strains are done in sitting. It's a counter strain for the tender point of teres minor and or infraspinatus. Infraspinatus has 3 different tender points typically. This is the spine of the scapula. They're usually at the corners of the triangle of that infraspinous fossa. But the most common trigger point is right here at the inferior angle. So to counter strain these, elbow flexed 90 degrees, extension and externally rotating the arm, and then just relax your arm here. That's it. Make sure the shoulder's relaxed. That will get rid of teres minor. Infraspinatus, you usually just have to drive a little bit more external rotation. Okay, so the difference between the two is minimal. They're both external rotation. You have to get a little bit more extension and a little more external rotation for the infraspinatus trigger point here versus teres minor. And that is the counter strain for the shoulder. Okay, this is a video on how to get hugged by your patients. Just kidding. This is a video on the mobilizations for the shoulder, and I'm going to do them specific to someone with frozen shoulder and the capsular pattern. So the capsular pattern is flexion is less limited than abduction, is less limited than internal rotation, and then external rotation is the most limited. We're going to mobilize in that order, okay? So first thing you want to do is a lateral distraction. Notice where my body is. I'm inside the armpit, I call it. My hand, the web space of my thenar eminence is here, as high up in the axillary region as I can get, and then I simply turn my body away. So notice how I'm turning my body away versus pushing with my arm. Okay, you just want to turn your body away. This is the lateral distraction. After you do 6 to 10 oscillations of that, just to kind of relax the joint, then you distract by turning away slightly, move your hand, put it on top of the proximal humerus, and now we're going to do a posterior glide in preparation for flexion. Okay, notice how I take up the slack and end range and then do an oscillation. Okay, but I'm not doing this large movement through the joint. I'm just taking up the slack and doing a small grade 3-4 mobilization and range. This is a posterior glide, and then I would stretch her into flexion, right? I would come here, stretch her into flexion. Okay, after I do my stretching and flexion, and I could use contract, relax, or dynamic stretching, then I would move on to improving abduction. So now I'm outside of the armpit, here, right over here. And so I'm going to put the web space of my hand again now off the acromion, relax your arm here, and I'm just going to apply an inferior glide of the humeral head here. Okay, notice again how it's really my body movement more than just my arm moving to do this mobilization. I do 6 to 10 oscillations in the inferior direction, and then I stretch her into abduction. A little trick here, if you go into elevation and you start to see the shoulder hike up, if you just take your hand and push the humerus inferior, you can a lot of times clear that pinch. So this is stretching into abduction after the inferior glide. Next one I want to address is internal rotation. So I'm going to glide posteriorly, still outside of the arm here, outside of the armpit. Put my hand here at the proximal humerus and do a posterior glide. And after I do the posterior glide here, I will stretch her into internal rotation. All right. And then lastly, I'm going to move her into external rotation and stand right back in the armpit and put my hand again on the proximal humerus, and this time do a posterior glide, but now with the arm in external rotation. So I'm trying to get her into her end range motion before I apply that glide. And then I'll stretch her into external rotation. And that is the mobilizations for the glenohumeral joint.